Welcome back to the deep dive. We're pulling up the anchor and plunging into another fascinating topic today, sent in by one of our curious listeners.
Indeed.
We're tackling a condition that affects millions, causes pain, and has a visible, often bothersome sign, the bunion. Or, if we're getting technical, hallux valgus.
It's a highly prevalent condition, certainly, and one that presents a complex challenge in orthopedics, both in understanding the intricate underlying mechanics and, well, deciding on the most effective management strategy for each individual.
Absolutely. And to guide our deep dive today, we have a stack of comprehensive sources, insights from places like the American Academy of Orthopedic Surgeons, the detailed information from OrthoBullets, and the extensive research compiled in NCBI Stat Pearls.
Good solid sources.
Our mission today is to unpack all of this material, giving you the absolute best shortcut to understanding what hallux valgus truly is beyond just that visible bump. Why it develops, how experts diagnose it, the full range of treatment options available, and, the latest thinking in the field. Get ready to become genuinely well-informed on bunions.
Synthesizing information from these respected expert sources is crucial for getting a truly comprehensive picture
Right.
of a condition that is, as you say, far more complex than meets the eye.
Yeah.
We're not just talking about a simple bump. We're talking about a structural issue affecting how the foot functions.
Okay, let's kick this off with a couple of striking numbers that really jumped out from the sources right away, challenging perhaps what many of us assume. Did you know that bunions, or hallux valgus, are found in approximately 23% of adults between 18 and 65?
That's a significant proportion.
It is already significant, but if you look at women and older adults, that number jumps dramatically up to 30 to 36%.
Yes, that increase with age is notable, reflecting the often progressive nature of the deformity. But perhaps even more striking, as one source highlights, is the gender disparity. Hallux valgus is reported to be up to 15 times more common in women than in men.
15 times. Wow.
Yes, and this isn't limited to populations wearing restrictive footwear. Even in groups who walk primarily barefoot, the prevalence is significantly higher in women.
15 times. That stat alone poses the core question we need to explore right away, doesn't it?
Indeed.
Is it really just about squeezing your feet into tight, pointy shoes and high heels, as is often blamed? Or is there something fundamentally more complex, likely related to genetics and foot structure, going on inside the foot that those shoes might simply make worse?
That's the crux of it.
That's the mystery these sources help us unpack. Welcome back to the Deep Dive, where we take that stack of articles, that research, those notes you sent us, and plunge into them to give you the essential knowledge in a way that's clear, engaging, and hopefully sparks a few aha moments. Think of it as your personal guided tour through the information.
A good way to put it.
And as always, I'm joined by our expert guide, who has this remarkable ability to synthesize complex medical information, connect the dots across diverse sources,
Try.
and explain not just the what, but the crucial why and the practical so what for someone looking to understand this condition.
Thank you. It's a pleasure to explore these materials. Hallux valgus might seem simple on the surface, a painful bump, but as the sources make clear, it's a very common condition, yet often misunderstood, with intricate underlying mechanics that affect how the foot functions with every single step.
Excellent. Before we dive into the nitty-gritty of the mechanics, let's do a quick rapid-fire setup
Okay.
to preview some key angles and maybe challenge a few common assumptions based on what the sources emphasize. So, first rapid-fire question. Beyond that visible bump, what is the absolute fundamental problem happening inside the foot when a bunion forms? Give us the core, simplified insight.
Right. The core issue, as the sources describe it, is a misalignment
A misalignment.
of the bones of the first ray, that's the bone behind your big toe, the first metatarsal, and the big toe bones themselves, the phalanges.
Okay.
The bone behind the toe, the metatarsal, angles inward towards the other foot.
Great.
And the big toe itself angles outward towards the second toe. This disrupts the main joint at the base of the big toe, the MTP joint, pulling it out of position.
Then that creates the bump.
That creates the visible prominence, yes. And importantly, it's not just a simple sideways shift. It often involves rotation as well, sort of a twisting motion.
Got it. A bone angle problem and a joint disruption, potentially 3D. Second rapid-fire question. We just talked about the gender disparity and the shoe question. Is there really a strong genetic link, according to these sources? And how do they characterize the role of shoe choice?
The sources confirm the genetic link is very strong.
Really?
Yes, family history is reported in a high percentage of cases, particularly in adolescent bunions, actually.
Interesting.
They position shoe choice, specifically those narrow, pointed shoes with heels, as an extrinsic factor.
Meaning external.
Exactly. Something external that exacerbates or irritates an underlying mechanical problem or genetic predisposition. It's generally not seen as the sole or primary cause itself in most cases.
So genetics loads the gun.
You could say that. The tendency towards the deformity is often inherited. The shoes just make it worse, or perhaps bring symptoms on faster or make them more noticeable.
So genetics loads the gun, and shoes might pull the trigger, but they aren't the only trigger. That's a key distinction. Final rapid-fire question. For someone dealing with a bunion right now, what's the single most important thing the sources want them to understand about non-surgical treatment options?
The critical takeaway, really, across all the sources, is that non-surgical treatment methods are primarily focused on managing symptoms.
It's just symptoms.
Yes, reducing pain and irritation, making shoes more comfortable. They do not correct or reverse the underlying bony or soft tissue deformity.
Right.
Understanding that the non-surgical goal is relief, not correction, is absolutely essential for setting realistic expectations.
Okay, those rapid-fire insights set the stage beautifully. Let's unpack this in detail, starting with exactly what Hallux Valgus is at its core. The sources are very specific about how to define this condition beyond just the visible sign.
Indeed. Hallux valgus is fundamentally described as a complex valgus deformity of the first ray.
Okay, break that down. First ray.
The first ray comprises the first metatarsal bone, that's the long bone in your foot leading to the big toe, and the phalanges, which are the bones that make up the big toe itself.
Got it.
The bunion prominence, that bump you see on the inside of the foot, isn't just an extra growth. It's actually the head of that first metatarsal bone sticking out because it's misaligned.
Ah, okay.
And crucially, the sources emphasize this as a three-dimensional deformity. It involves malalignment, not just sideways, but also in the vertical and rotational planes, sort of up and down and twisting as well.
Right, so it's not just a simple sideways shift. It's more like the bone twisting and angling out. Tell us about the key anatomy involved at the center of this.
The primary joint where this deformity manifests is the metatarsophalangeal joint, or MTP joint for short.
The main toe joint.
Essentially, yes. The main knuckle at the base of your big toe, where the head of the first metatarsal bone connects with the base of the proximal phalanx, the first bone of the big toe.
Okay.
The big toe itself has two joints, but the bunion problem is focused right here at that MTP joint.
Got it. The main pivot point for the big toe. So how do these bones get out of that healthy alignment? What's the process?
Well, the sources detail a specific sequence of events in what we call the pathoanatomy. The first metatarsal bone, the one behind the big toe, abnormally angles medially.
Medially meaning towards the middle.
Toward the middle of your body, yes. Or inward relative to the other metatarsals. At the same time, the phalanges, the bones of the big toe, angle laterally away from the midline, deviating towards the second toe.
Okay, so they go in opposite directions.
Precisely. And it's this angulation at the MTP joint, combined with that medial shift of the metatarsal head, that causes that part of the bone to protrude noticeably on the inner side of the foot.
And that protrusion is what gets called the bunion, and where the pain often starts.
Exactly. That prominent, misaligned MTP joint area is subjected to abnormal forces during walking. And, of course, direct pressure from shoes. This often leads to inflammation of the joint capsule and surrounding tissues, sometimes including a bursa, which is a small fluid-filled sac that can form over bony prominences.
Inflammation. And that's the redness and swelling.
Yes. The sources note the very word bunion actually comes from the Greek word for turnip.
A turnip.
Really?
Which graphically describes that typical red, swollen appearance you often see due to this inflammation.
A turnip. Yes. That visual is certainly memorable. And the sources are clear this is usually a progressive issue. It gets worse over time.
Yes, that's a key point. Bunions typically don't appear fully formed overnight. They often start as a mild deviation and tend to worsen gradually over time.
Why is that? Well, the MTP joint is a critical part of the foot's push-off mechanism during walking. With every step you take, force goes through that joint. As the misalignment increases and the bunion becomes larger, this abnormal motion and pressure make walking increasingly painful and difficult. In more advanced cases, the big toe can drift so far laterally.
Towards the other toes?
Yes, that it crowds, overlaps, or even underlaps the second toe. This pushes the second toe out of alignment too, and can potentially cause secondary problems like hammer toes, corns, or painful calluses under the ball of the foot due to the altered weight distribution.
It sounds like a real chain reaction, starting with that initial bone shift. And the sources really dig into the complex biomechanics and soft tissue changes involved. It's not just the bones moving, is it?
Not at all. That's a critical point. The bony malalignment initiates a cascade of changes in the surrounding soft tissues, the muscles, tendons, and ligaments. And these soft tissue changes actually contribute to and worsen the deformity over time. There's an imbalance that develops between the different muscle groups controlling the big toe.
How so?
Well, as the first metatarsal shifts medially, the small sesamoid bones.
Sesamoids, what are they?
They're two small pea-sized bones embedded within the tendons that run underneath the first metatarsal head. They act like small pulleys.
Oh, okay.
They're crucial for normal tendon function and weight-bearing under the ball of the foot. In Hallux Valgus, these sesamoids get pulled out of their normal groove on the underside of the metatarsal head and displaced laterally towards the smaller toes.
So the bones shift and these pulley-like bones shift too, messing up the machinery.
Exactly. This sesamoid displacement is a hallmark of Hallux Valgus and significantly alters the biomechanics under the ball of the foot.
How does that affect things?
It affects how the tendons that use the sesamoids function, particularly the flexor hallucis brevis muscle. It also shifts weight-bearing pressure, often increasing the load on the lesser metatarsal, heads the bones behind the smaller toes.
Leading to pain there.
Yes, leading to that common symptom of pain under the ball of the foot, which is known as transfer metatarsalgia. Simultaneously, the ligaments and the joint capsule on the medial side of the MPP joint, the side with the bump, get stretched and weakened over time.
Okay.
Well, the structures on the lateral side, the side towards the second toe, become tight and contracted.
It's like the joint capsule becomes too loose on one side and too tight on the other.
Precisely. And this imbalance further pulls the toe out of place, and key muscles actually become deforming forces.
How does that work?
For example, the adductor hallucis muscle, which normally helps stabilize the toe, gets pulled into an abnormal position due to the metatarsal shift. Instead of stabilizing, it effectively starts pulling the big toe further laterally towards the second toe, worsening the deformity.
So a muscle that should help actually starts hurting.
In effect, yes. Even the extensor hallucis longus tendon, the main tendon that lifts the big toe up, can slip laterally off the top of the joint and add to the sideways pull. And one subtle but important point from the sources is how the abductor hallucis muscle, which is typically on the inside edge of the foot, can migrate downwards and outwards.
And that does what?
That contributes to the pronation or twisting of the big toe. The toe doesn't just angle sideways, it often rotates so the nail points inward slightly. This reinforces the 3D nature of the deformity we mentioned earlier.
It's a whole system of checks and balances falling apart, isn't it? And the windlass mechanism is affected too, right? How does that tie in?
The windlass mechanism is, well, it's a fascinating piece of foot biomechanics. It essentially describes how the plantar fascia, that thick band of tissue on the sole of your foot, acts like a winch or a spring during the push-off phase of walking.
Okay.
As your heel lifts and your big toe bends upwards, the plantar fascia tightens, which lifts the arch of your foot, making it a more rigid lever for efficient propulsion.
Like winding up a spring.
Exactly.
Yep.
Proper function of the big toe MTP joint and the correct positioning of those sesamoid bones are crucial for this spring to load and unload effectively.
And with a bunion.
With the sesamoids displaced and the MTP joint misaligned and often stiffening up, this windlass mechanism becomes less efficient. The foot might not gain the same arch stability during push-off.
What's the consequence of that?
It can contribute to overall foot instability and, again, potentially push more pressure onto other parts of the forefoot, contributing to that transfer pain.
Fascinating how one initial shift can lead to such a cascade of mechanical problems affecting the entire foot's function. The sources also differentiate between types of bunions. It's not all the same thing.
No, not entirely. Beyond the common adult Hallux Valgus, they describe adolescent bunions.
Right, you mentioned those.
These occur in younger individuals, typically girls between the ages of 10 and 15, often before their skeleton is fully mature.
And they're strongly linked to family history.
Very strongly associated with a positive family history, yes. Which really underscores that genetic link we discussed earlier. Pain is often less prominent in adolescent bunions compared to adults, and they may retain more flexibility in the MTP joint.
But there's a caution there.
Yes. The sources specifically note a higher risk of the bunion coming back, recurrence. if these are surgically treated before the growth plates in the foot bones have closed, meaning before the foot is fully mature. Timing is important there.
Good information for parents to be aware of. And what about the bunionette? That sounds smaller.
That's also known as a tailor's bunion. It's essentially similar mechanics but occurs on the outside of the foot.
On the little toe side.
Exactly, at the base of the little toe, involving the fifth metatarsal bone. It involves the little toe shifting inward towards the fourth toe and the head of the fifth metatarsal bone becoming prominent on the outside edge of the foot.
And presumably gets irritated by shoes, too.
Very much so. Often irritated by shoe pressure, hence the name tailor's bunion. Historically, tailors would sit cross-legged, putting pressure on that outer part of the foot.
Ah, that makes sense. So we've dissected what hallux valgus is mechanically. Let's broaden out now to the causes and risk factors. You've already challenged the idea that it's just about shoes. What else do the sources list?
Right. The sources consistently highlight a multifactorial etiology.
Meaning multiple factors.
Yes, usually not one single cause, but a combination. Poorly fitting shoes are definitely listed as a factor, but primarily as an exacerbating one.
Making it worse, not necessarily causing it.
Precisely. They specifically mention shoes with a narrow pointed toe box that squeezes the forefoot and forces the big toe sideways.
And heels.
And shoes with heel lifts significantly higher than, say, a couple of inches. These shift weight forward onto the forefoot and increase pressure on the MTP joint. But as one source points out,
yes,
the simple fact that not everyone who wears these shoes develops bunions, and conversely, some people who wear very sensible shoes do develop them, supports the idea that shoes aggravate an underlying issue rather than exclusively causing the problem in the first place.
So the underlying predisposition is key, and shoes just make it worse, faster, or more symptomatically painful.
Exactly. And that underlying predisposition is strongly linked to heredity and genetics.
The 70% figure you mentioned?
Family history is present in approximately 70% of patients, particularly, as we noted, in adolescent cases. It's believed that people inherit certain foot shapes, structures, or mechanical tendencies.
Like what specifically?
Such as the angle of the metatarsal bones relative to each other, the shape of the joint surfaces, the flexibility of the joints or ligaments, or the balance of muscle forces around the foot. These inherited traits can make them more susceptible to developing the deformity over time.
Are there any specific foot structures that make you more prone, things you can sort of see or feel?
Yes, the sources list several structural variations. These include things like variations in the length or angle of the first metatarsal bone itself, for example, a first metatarsal that's shorter than the second, or one that points slightly upwards, what we call dorsiflexion.
Okay.
Also, specific forefoot alignments like forefoot varus, where the forefoot angles inward relative to the hindfoot, generalized ligamentous laxity.
Being sort of double jointed.
Exactly. Having generally loose ligaments throughout the body can affect the foot too. Pes plana valgus, which is essentially flexible flat foot, where the arch collapses excessively under weight.
Right.
Or excessive mobility or instability at the joint behind the first metatarsal, the TMT joint we mentioned earlier, sometimes called first-ray hypermobility.
Mm-hmm.
All these structural factors can contribute to instability and abnormal mechanics that can initiate or worsen the deformity.
And you mentioned certain medical conditions could be linked as well.
They can, yes.
Yeah.
Inflammatory conditions that affect joints are a key group. Things like rheumatoid arthritis, gouty arthritis, and psoriatic arthritis can damage the MTP joint and contribute to deformity.
Makes sense.
Neuromuscular conditions are another category. These affect muscle control and balance. So conditions like Charcot-Marie-Tooth disease, the effects of polio or stroke, cerebral palsy, or myomeningocephaly can lead to muscle imbalances that result in foot deformities, including hallux valgus.
Right.
And finally, connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, and Down syndrome are also mentioned, primarily because they often involve increased ligamentous laxity, contributing to joint instability.
So it's a really complex picture, a mix of your genetic blueprint, your inherited foot structure, potentially other health issues you might have, and then environmental factors like your shoe choices all playing a role.
Absolutely. And age is a factor, too, with prevalence increasing over 65.
Now let's talk about the symptoms. Beyond the obvious bump, what else might someone experience? What should you look out for?
The visible bump is often the most noticeable sign, of course, but it's usually the pain and discomfort that typically drive people to seek medical attention.
Where does the pain usually occur?
The sources list pain and tenderness, which can be directly over the bony prominence where it rubs against shoes. That's very common. Or pain within the MTP joint itself due to the abnormal mechanics and potentially developing arthritis in the joint. And sometimes, as we discussed, pain under the ball of the foot due to that altered weight distribution, the transfer metatarsalgia.
And the look of it, redness, swelling.
Yes, redness, swelling, and inflammation around the joint are common, particularly after prolonged standing or activity, or simply due to shoe pressure irritating the area.
And it affects the skin, too, calluses and things.
Yes, the constant friction and pressure can lead to hardened skin, calluses, or corns developing. These might be directly on the bunion bump itself, or sometimes on the sole of the foot beneath the misaligned joints where pressure is increased, or even between the toes if the big toe is pushing against the second toe.
Okay. What about movement?
Stiffness and limited range of motion in the big toe MTP joint are also typical symptoms. This can make activities like walking, running, or even just bending the toe difficult or painful.
And the other toes get involved.
As the deformity worsens, the big toe can press on or push the second toe out of the way. This can lead to pain, calluses, or corns forming between the first and second toes, what's called interdigital keratosis. Or it can push the second toe upwards or sideways, leading to hammer toe deformities in the lesser toes.
So it really can disrupt the whole front of the foot.
It can. Also, compression of small nerves in the area, particularly the digital nerve running along the side of the toe, can cause burning, tingling, or numbness, a condition sometimes called neuritis. The chronic irritation can also lead to bursitis, that inflammation of the fluid-filled sac, or progressive degenerative joint disease, essentially arthritis, within the MTP joint itself over time.
So it's far more than just a cosmetic issue. It's clearly a functional problem causing pain, disrupting how you walk, and potentially leading to a whole cascade of other foot issues.
Precisely.
Thinking about that whole list of causes and risk factors, genetics, foot structure, other medical conditions, shoe choices, age. For someone who is perhaps developing a bunion or trying to prevent one from worsening, which of those factors, based on what the sources say, are the most directly controllable or modifiable by the individual?
That's a key practical question. Based on the sources, the most significant modifiable factor is undoubtedly footwear.
Back to the shoes again.
Yes. While you can't change your genetic predisposition or the fundamental inherited structure of your foot, consciously choosing shoes that accommodate your foot shape is crucial.
What does that mean in practice?
It means shoes with wide toe boxes that provide ample room for the toes to spread naturally, not be squeezed together. Low heels, generally below a couple of inches to avoid excessive pressure on the forefoot. Soft, flexible soles can also help. And ensuring the shoe is long enough for your longest toe and fits comfortably at the end of the day when your foot might be slightly larger or more swollen.
And doing that can actually help.
It can substantially reduce the external irritation and pressure on the MTP joint. This can certainly help manage symptoms, potentially slow the progression of the deformity by reducing those aggravating factors, and improve comfort significantly. It's about removing the external stressor.
Any other controllable factors?
Well, managing any underlying inflammatory or neuromuscular conditions with appropriate medical treatment is also a form of intervention, of course. Though that's not about directly modifying the bunion itself, but rather addressing a contributing root cause if one is present. But for most people, footwear is the main thing they can directly control.
That makes sense. Focus on the shoes, manage any related health conditions. Okay, now that we understand what hallux valgus is, how it develops, and what its symptoms are, let's transition to how doctors evaluate this condition and figure out the best way forward for an individual.
Right, the diagnostic process.
Here's where it gets really interesting.
That-
How do doctors take all this complexity and figure out exactly what's going on with your bunion and what the best options are?
The diagnostic process is comprehensive, as you'd expect. It combines patient information, a detailed physical examination, and essential imaging studies, primarily x-rays.
So it starts with just listening to the patient, having a good chat.
Absolutely. A thorough patient history is crucial. The doctor needs to understand the patient's specific symptoms, the location, nature, and duration of the pain, how it impacts their daily activities, their work, any sports they do, and crucially, their shoe wear. What can they tolerate? What can't they? They'll ask about the progression of the deformity and symptoms over time. Has it changed recently? Gotten worse quickly? Medical history is important too, to identify any predisposing conditions like inflammatory arthritis or neuromuscular disorders we mentioned, and family history is essential given that strong genetic link.
And then the physical exam. You mentioned earlier the distinction between non-weight-bearing and weight-bearing exams is important. Why is that distinction so critical?
That distinction is key because the foot's mechanics and alignment change significantly when it's supporting your body weight, compared to when it's relaxed, say sitting on the examination couch.
Right.
The non-weight-bearing exam allows the doctor to assess the flexibility of the deformity. Can the toe be manually straightened? They check the range of motion at the MTP joint. The sources indicate a normal range is typically less than 15 degrees of downward bend, or plantar flexion, and perhaps 65 to 75 degrees of upward bend, or dorsiflexion. Is it stiff? Does it move freely?
What else do they check non-weight bearing?
They'll feel for pain, swelling, tenderness, or any grinding sounds, what we call crepitus within the joint.
Yeah.
They assess the overall axis of motion. Is the joint stable, or does it feel loose?
And the weight bearing part, when you stand up.
The weight-bearing exam shows how the deformity behaves under load, under the stress of supporting the body. The doctor observes how much the big toe angles laterally when standing, how prominent the bunion lump becomes. They assess the purchase, how well the big toe makes contact with the ground during standing, and perhaps while taking a few steps. Does it lift off? Does it roll?
Looking for dynamic issues.
Exactly. Looking for dynamic alignment issues and also checking for associated conditions like excessive arch flattening, pes planus, or abnormal rotation of the foot under weight. Equally important is examining the entire foot and ankle
Why the whole foot?
to identify any associated deformities that might contribute to the bunion or be caused by it. Things like hammer toes in the lesser toes, any signs of neuromas between the toes, assessing for excess flexibility or hypermobility in the midfoot, or checking for tightness in the calf muscles or Achilles tendon, what's called an equinus contracture, as that can affect foot mechanics significantly. A check of nerve function and blood supply to the foot is also routine.
So they're really assessing the structure and how it performs under stress. What about imaging? The sources really highlight X-rays.
X-rays are considered indispensable for evaluating Hallux valgus. Absolutely essential.
Why so crucial?
They are essential for confirming the diagnosis, for quantifying the severity of the bony deformity, for identifying any arthritis or damage within the joint itself, and critically, for providing the blueprint needed for planning any surgical correction if it comes to that.
And again, you stress they need to be weight-bearing X-rays. Why not just lying down?
Absolutely. A weight-bearing X-ray series, typically including views from the front to back, AP, the side, lateral, and an oblique angle, is crucial because it captures the bones in their functional alignment.
When they're actually doing their job.
Precisely. When the foot is bearing load. This provides the most accurate representation of the deformity's magnitude and helps reveal dynamic instabilities, or how different parts of the foot relate to each other under pressure, which might be hidden on a non-weight-bearing X-ray.
Are there special views they look at beyond those standard ones?
Yes. Beyond the standard views, a specific sesamoid view is frequently obtained.
To see those little pulley bones.
Exactly. This is often an axial view, looking sort of up at the ball of the foot from below. It's vital for evaluating the position of those small sesamoid bones relative to the underside of the first metatarsal head. Their displacement, as we discussed, is a key indicator of the progressive subluxation or dislocation of the MTP joint.
Anything else they look for on the X-rays?
The sources mentioned looking for the round sign on the standard AP X-ray. This can be a subtle indicator of rotational deformity or pronation of the metatarsal head relative to the sesamoids, linking back to that 3D concept again.
It sounds like they're playing detective with these images, looking for clues, and they use those angles you mentioned in the rapid fire to measure things precisely.
Exactly right. The X-rays allow for precise measurement of several key angles, which are crucial for quantifying the deformity, classifying its severity, and guiding treatment decisions. Let's recap those. The Hallux Valgus angle, HVA. That's the angle between the long axis of the first metatarsal and the long axis of the proximal phalanx, the first toe bone. Normal is less than 15 degrees. This tells you how much the toe itself is angled outwards at the MTP joint.
Right.
The intermetatarsal angle, IMA. The angle between the long axis of the first metatarsal and the second metatarsal. Normal is less than 9 degrees. This is critical because it measures that medial deviation, how far the first metatarsal has splayed inwards away from the second. A higher IMA means more splaying, a bigger gap.
Got it. HVA is the toe angle, IMA is the metatarsal splay.
Correct. Then there's the distal metatarsal articular angle, DMAA. This measures the orientation of the joint surface at the end of the first metatarsal relative to its long axis. Normal is less than 10 degrees. It's meant to indicate if the joint surface itself is tilted sideways.
Is that reliable?
Well, the sources note its measurement can be variable, and importantly, a high DMAA might actually reflect the rotation or pronation of the metatarsal head more than a true tilt of the joint surface itself. So it needs careful interpretation in that 3D context.
Okay. What else?
The Hallux Valgus interphalangeus, HVI. This is an angle measured within the proximal phalanx of the big toe itself. Normal is less than 10 degrees. And increased HVI means the toe bone itself has a bend in it, contributing to the overall crooked appearance.
So the bend isn't just at the main joint.
It can be within the toe bone too, yes. And finally, the metatarsus adductus angle. This measures how much the entire forefoot is angled inward relative to the back of the foot. Normal is less than 10 degrees. A higher metatarsus adductus angle signifies an underlying foot shape that predisposes someone to bunions, often coexisting with a high IMA.
So these angles are like the precise coordinates or the blueprint of the deformity, showing exactly where the problem lies is the toe angle, the metatarsal splay, the joint tilt, a bend in the toe bone, or the whole forefoot shape and how severe it is.
Precisely. They quantify the different components of the deformity.
Are there other imaging tools used besides X-rays?
The sources mention that weight-bearing CT scans are becoming increasingly valuable, especially for surgical planning.
CT scans.
Yes. They provide a detailed three-dimensional assessment, clearly showing the deformity in the transverse plane, sideways, the sagittal plane, up-down, and, critically, the frontal plane, which shows that rotational component, the pronation, that standard 2D X-rays might not fully capture or quantify accurately.
So even better for understanding the 3D aspect.
Exactly. MRI isn't typically used for standard bunion evaluation, but might be ordered if there's suspicion of other issues like soft tissue masses, nerve impingement, stress fractures, or bone infection. And lab studies like blood tests are generally only ordered if there's a clinical suspicion of a systemic condition like rheumatoid arthritis or gout contributing to the foot problem, checking things like inflammatory markers or uric acid levels.
With all these measurements and images, how do doctors then classify bunions? Is there a standard system?
Traditionally, yes. Bunions have been classified based primarily on the severity of the deformity, using those HVA and IMA angles measured on the weight-bearing X-rays.
What are the categories?
The sources give ranges for this traditional system, though they can vary slightly, generally. Mild deformity typically means an HVA below 20 degrees and an IMA perhaps between 9 and 11 degrees. Moderate might be an HVA between 20 and 40 degrees and an IMA between, say, 11 and 16 degrees. And severe deformity is generally classified with an HVA over 40 degrees and an IMA over 16 degrees.
And this classification guided treatment?
Historically, yes. The general rule of thumb was that the severity category helped guide the choice of surgical procedure. Milder deformities might be addressed with procedures near the end of the metatarsal, while more severe ones often require procedures further back towards the base of the bone or even further back still.
But you've emphasized the 3D nature repeatedly. Does the classification reflect that now? Is it changing?
Yes, and this is a key development highlighted in the sources. A newer emerging classification system is often referred to as the triplanar or anatomic-based classification.
Triplanar meaning 3 planes.
Exactly. This system moves beyond just the 2D angle seen on standard X-rays and specifically takes into account the deformity in all 3 dimensions: the sideways shift, transverse plane, the vertical angle, sagittal plane, and critically the rotation of the first metatarsal, frontal plane pronation.
How does it categorize them?
It categorizes bunions into different types based on combinations of the HVA and IMA, the degree of metatarsal pronation or twisting, the extent of sesamoid displacement or subluxation, the presence or absence of metatarsus adductus, and whether there's significant arthritis or degenerative joint disease, DJD, at the MTP joint.
So it's much more deep.
It is. It aims to provide a more comprehensive anatomical description. This newer, more complex understanding of the deformity is directly influencing modern surgical techniques. It's driving the shift towards procedures that can correct the deformity in all 3 planes simultaneously, aiming for a more complete and potentially more stable, long-lasting correction.
That makes sense.
Validation studies for this new system are ongoing, but it definitely reflects the current thinking on the condition's true multiplanar nature.
That makes perfect sense. A 3D problem often needs a 3D solution, or at least a 3D understanding to plan the right 2D or 3D correction. Let's talk treatment then. The sources seem very clear that non-operative management is the first step. What's the philosophy behind that? Why start there?
Non-operative management is consistently presented as the initial approach for symptomatic relief, and this is crucial. Its goal, based on all the sources, is to decrease pain and irritation and make shoe wear more comfortable. It does not correct or reverse the underlying bony malalignment or the soft tissue imbalances that create the bunion bump in the crooked toe. It's about managing the consequences, not fixing the fundamental structure.
So it won't make the bump smaller. or straighten the toe permanently.
No, not the actual bony prominence or those angles we talked about. The cornerstone of non-operative treatment, highlighted across all the sources, is modifications in footwear. We keep coming back to this.
Right. Tell us again what that involves.
Choosing shoes with a wide, deep toe box that provides ample room for the toes to spread naturally. Avoiding shoes that squeeze the forefoot or put direct pressure on the bump. Low heels are important, generally below a couple of inches, to reduce pressure on the forefoot MTP joints. Soft, flexible soles can also improve comfort. And ensuring the shoe is the right length and fits comfortably, perhaps trying them on at the end of the day when your feet might be slightly larger or swollen.
So it's about giving the foot space and reducing pressure.
Exactly. The idea is to reduce direct pressure and friction on the bunion and avoid forcing the toes into a deformed position.
What other non-operative strategies are mentioned? What else can people try?
Padding is commonly used. Things like using felt or silicone pads over the bunion prominence to cushion it from shoe pressure, or placing soft material like lamb's wool or silicone spacers between the first and second toes to reduce rubbing or try and align them slightly.
Do they work?
They can help cushion the area and reduce friction. However, the sources caution that padding needs to be placed correctly. Sometimes adding bulk inside a shoe can inadvertently increase pressure elsewhere if the shoe is already tight.
Fair enough. What about inserts or splints?
Orthotics and other shoe inserts, either over-the-counter or custom-made, can help support the foot's arch and potentially improve foot mechanics. This may indirectly reduce strain on the MTP joint, although their direct effect on the bunion deformity itself is generally considered limited. Devices like toe spacers worn during the day or night splints that hold the toe in a straighter position are sometimes used.
Do the splints straighten the toe over time?
The sources explicitly state that while these might provide temporary symptomatic relief for some people, perhaps stretching tight structures slightly, they have not been shown to permanently correct the bunion deformity. The bones won't reshape from wearing a splint.
Right. Comfort, not correction. And for pain relief itself.
Over-the-counter or prescription non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen or naproxen, are often recommended. They can help reduce pain and inflammation around the joint, especially during flare-ups.
Okay.
In cases linked to specific inflammatory conditions like gout or rheumatoid arthritis, then obviously other medications aimed at treating the underlying systemic disease are crucial. Steroid injections directly into the MTP joint or the bursa over the bunion are sometimes used for significant inflammation and pain, but this is generally used cautiously and sparingly. It's not usually a long-term solution, as repeated steroid injections can potentially weaken tissues.
It really sounds like non-surgical treatment is primarily about comfort and managing the symptoms of the deformity, managing the pain and shoe fitting issues, rather than addressing the structural issue itself. Is that the central message here from these sources?
That is absolutely the central message regarding non-surgical care. The goal is symptom management, improving comfort, maintaining function as much as possible despite the deformity.
And when does it fail? When do you move on?
When non-surgical treatment is deemed to have failed, according to the sources, it generally means that despite consistent efforts with appropriate footwear, padding, activity modification, and perhaps pain relief medication, the patient's pain level remains unacceptable, or that difficulty with walking and wearing necessary shoes significantly impacts their daily life, their work, or their desired activities. Their quality of life is compromised by the symptoms.
Right.
At that point, when conservative measures aren't enough to provide adequate relief and maintain function, then the conversation turns towards surgical correction.
That transition is clear. So what happens when managing the symptoms isn't enough and the pain is still impacting your life? What does the world of surgical solutions look like? And why on earth are there so many different procedures described in the sources? It seems bewildering.
It can seem that way, yes.
Okay, let's talk about surgical correction. When is surgery actually considered the right step? And what is the primary goal once you decide to go down that path?
According to the sources, the primary indication for surgery is symptomatic Hallux Valgus. That means persistent pain and functional limitation, specifically difficulty walking or wearing necessary reasonable shoes comfortably that has not improved despite adequate attempts at non-surgical management over a reasonable period.
So pain and function are key, not just how it looks.
Absolutely. There is a strong consensus across the sources that surgery should never be undertaken for purely cosmetic reasons, simply to make the foot look better. The risks and recovery involved are significant.
Okay, so what's the goal of surgery then?
The main goal of surgery is to relieve pain and improve function. This is achieved by surgically realigning the bony structure of the first ray, balancing the surrounding soft tissues, those ligaments and tendons we talked about, and restoring a more normal, stable position to the big toe and the MTP joint.
And the aim is?
The aim is to allow for more comfortable weight-bearing, improved foot mechanics during walking, easier and more comfortable shoe wear, and ultimately a better quality of life for the patient.
The number of procedures mentioned is staggering. The sources say over 100 described. How do surgeons possibly choose which one to do?
It's true. The sheer variety reflects the complexity and variability of the deformity itself. No two bunions are exactly alike. Surgeons need a range of tools, a range of techniques to address the different aspects of the problem in different patients. The choice of procedure, or more commonly, a combination of procedures.
It's often more than one thing done at once.
Very often, yes. It depends on several factors. The specific nature and severity of the deformity based on the clinical exam and those radiographic angles we discussed, the HVA, IMA, DMAA, HVI. The presence of associated conditions like arthritis in the joint or instability, or that metatarsus adductus foot shape. The patient's age, their activity level, their overall health, bone quality. And of course, the surgeon's experience and training with particular techniques plays a role.
So it's highly individualized.
It has to be. Generally, procedures are chosen to address the specific components of the deformity that are most prominent in that individual's foot, based on that detailed preoperative assessment.
Can you walk us through the main types of procedures and what they fundamentally do? Just the broad categories first.
Broadly speaking, surgical procedures for hallux valgus fall into several main categories based on the primary action they take.
Okay.
Osteotomy. This is probably the most common type of procedure overall. It involves surgically cutting and reshaping a bone.
Cutting the bone.
Yes, usually the first metatarsal or sometimes the proximal phalanx, the first toe bone. The bone is cut, repositioned to correct the alignment, and then typically fixed in place with small screws or pins while it heals. Think of it like bone carpentry to change the angles.
Right. What else?
Arthrodesis. This involves surgically fusing a joint.
Fusing, making it solid.
Exactly. The cartilage surfaces of the joint are removed, and the bones on either side are prepared and held together, usually with plates and/or screws, so that they grow together into one solid piece of bone. This eliminates motion at that specific joint, but crucially, it also eliminates pain that might be coming from a damaged, arthritic, or severely misaligned joint.
Where do they fuse joints for bunions?
It's typically done either at the main MTP joint at the base of the big toe, or sometimes further back at the tarsometatarsal TMT joint, where the first metatarsal meets the midfoot bones.
Okay, next category.
Arthroplasty. This involves reshaping or removing part of the joint surfaces. A historical example is the Keller procedure, where the base of the proximal phalanx, a toe bone, is removed.
Is that common now?
The sources note that simple resection arthroplasty like the Keller is now largely abandoned for most active patients. It can lead to instability, a floppy toe, or unpredictable results. It's generally reserved for very specific cases, perhaps in low-demand elderly patients or as part of managing very complex revisional situations where other options aren't feasible. Joint replacement implants for the MTP joint also exist, but the sources suggest they've had variable success in the foot compared to major joints like the hip or knee, with concerns about longevity and wear.
Okay, any other types?
Soft tissue procedures. These involve surgically releasing tight structures or tightening loose structures, ligaments, tendons, or the joint capsule to help balance the forces pulling on the big toe.
Are they done on their own?
Rarely performed alone for anything other than the mildest deformities, if at all. They're often done in conjunction with bony procedures, osteotomies or fusions, to help maintain the correction achieved by the bone work and prevent recurrence. A historical example is the modified McBride procedure, which primarily focused on soft tissue release and transferring a tendon, but the sources emphasize it's insufficient to address the underlying bony deformity alone in most cases, and is rarely used as a primary procedure now. It doesn't fix the misaligned bones.
Okay, so osteotomies cut and realign bone, arthrodesis fuses a joint, arthroplasty reshapes, replaces, less common now, and soft tissue procedures balance tendons, ligaments, usually as an adjunct. Can you give us examples of specific techniques linked to the severity or location of the problem, drawing from the sources? Tie it back to those angles.
Certainly. The choice often relates to addressing the specific components of the deformity identified by the angles and the clinical exam.
Right. Mild cases first.
For mild to moderate deformities, particularly those where the IMA, that splay angle, is not excessively high, say, below 13 or 14 degrees, and there isn't significant arthritis in the MTP joint, distal metatarsal osteotomies are common.
Cuts near the toe end.
Exactly. Procedures like the chevron osteotomy, which is a V-shaped cut, or slightly larger variants like the biplanar chevron or long-arm chevron, involve making a cut near the head of the first metatarsal. This allows the surgeon to slide the metatarsal head laterally towards the second metatarsal, effectively reducing the IMA and correcting the position relative to those sesamoid bones underneath.
Okay, that makes sense for smaller corrections. What about moderate to severe?
For moderate to more severe deformities, especially with a higher IMA, say 14, 15, 60 degrees or higher, or where a larger shift of the metatarsal is needed, surgeons often turn to diaphyseal osteotomies, which are cuts in the shaft of the bone, like the scarf osteotomy, a Z-shaped cut. Or, very commonly, proximal metatarsal osteotomies.
Cuts near the base of the bone.
Yes, performed near the base of the first metatarsal, further back in the foot. Examples include a proximal chevron, a crescentic curved osteotomy, or opening or closing wedge osteotomies where a wedge of bone is either added or removed to change the angle.
Why cut further back?
These cuts are made further back on the bone's shaft or base and generally allow for greater correction of the IMA, that splay angle, compared to discal procedures. Proximal osteotomies are often considered for more significant IMAs because they offer powerful correction, although they can sometimes have a slightly longer healing time as the bone at the base is less vascular.
And the fusion options, when are they used?
The tarsemetatarsal, TMT arthrodesis, famously known as the lapidus procedure, is a crucial procedure in the armamentarium.
Lapidus. Oh.
It's particularly indicated for severe deformities, especially those with a very high IMA, or cases with significant instability or hypermobility identified at the base of the first metatarsal, to that TMT joint, or in patients with associated flatfoot, pes planovalgus, where the first ray might be elevated or unstable.
What does it do exactly?
This procedure involves fusing the joint where the first metatarsal meets the mid-foot bones, the first cuneiform. The rationale is that for many severe bunions, the root of the problem isn't just a bend in the metatarsal itself, but instability or malalignment originating further back at this foundational TMT joint.
So fixing the root cause.
Exactly. By fusing this joint in a corrected position, the surgeon can address the source of the instability and effectively bring the entire first metatarsal back into better alignment, significantly reducing a high IMA. Newer lapidus techniques specifically focus on correcting the 3D deformity, including that pronation or rotation, at this foundational joint level. It's seen as a very powerful corrective procedure for the right indications.
Okay. And the other fusion, fusing the main toe joint.
MTP arthrodesis, fusing the big toe joint itself, the metatarsalophalangeal joint, is often the procedure of choice in several situations. For severe deformities where there is also significant degenerative joint disease or arthritis within the MTP joint causing pain. For complex revisional cases after previous bunion surgeries have failed, or in patients with certain neuromuscular or inflammatory conditions where achieving a stable, functional joint with preserved motion is likely to be difficult or unpredictable.
What's the outcome of fusing the main toe joint?
While it obviously eliminates motion at that joint, you won't be able to bend the big toe up and down at that knuckle. It reliably removes pain originating from a diseased joint. It also provides a very stable, lasting correction of the alignment and allows patients to push off strongly during walking without painful MTP joint movement. Patient satisfaction is often very high when indicated appropriately.
And that other osteotomy you mentioned, the Aiken.
An Aiken osteotomy is very commonly used, but usually as an adjunct procedure.
Meaning done alongside something else.
Exactly. It's performed in addition to a metatarsal osteotomy or fusion. It involves taking a small wedge of bone out of the proximal phalanx, the big toe bone itself, and closing the gap, usually fixing it with a small staple or screw.
Why do that?
It's specifically used when there is a significant sideways bend within the big toe bone itself. Remember that high HVI angle we measured? The Aiken helps to straighten the toe cosmetically and functionally after the main metatarsal deformity has been corrected further back. It fine-tunes the final toe position.
Okay. And lastly, minimally invasive surgery. Is that becoming more common?
Finally, yes, the sources discuss minimally invasive surgery, MIS techniques, at an evolving area. These procedures use very small incisions, often just keyholes, and specialized long, thin instruments and burrs guided by intraoperative X-ray, fluoroscopy, to perform the bone cuts, osteotomies, or other corrections.
What are the supposed benefits?
The potential advantages cited are reduced soft tissue disruption compared to traditional open surgery, smaller scars, and potentially faster early recovery or return to certain activities like driving or wearing wider shoes. However,
Yes.
the evidence base comparing MIS outcomes directly to established open techniques is still developing, particularly regarding long-term results and recurrence rates. It requires specific training and experience, and the overall recovery timeline for full bone healing and return to high-impact function may still be quite similar to open procedures in the end. It's an area of active development and research.
Wow, that's a comprehensive overview of how the the angles, the arthritis, the instability really drives the surgical solution. With so many options, it definitely reinforces that a thorough diagnosis with those angles and potentially that 3D classification is absolutely key.
It really is paramount.
What about recovery after surgery? You hear stories. Is it always a long and difficult process? What should people realistically expect?
Recovery is definitely a process, and expectations need to be realistic. While many bunion surgeries are performed as same-day procedures, meaning you go home the same day,
Right.
the recovery process itself is certainly not instant and requires significant patience and adherence to the post-operative instructions given by the surgeon. The sources generally describe recovery as a period of months, not weeks, for a full recovery.
Months.
Yes. Immediately after surgery, the foot is protected in dressings, often quite bulky, and usually a special surgical shoe or boot, or sometimes even a cast, depending on the specific procedure performed and the surgeon's preference.
And can you walk on it straight away?
Weight-bearing status varies greatly. This is a key point. Some procedures, particularly distal osteotomies for milder deformities, might allow immediate partial or full weight-bearing in the protective shoe or boot. However, other procedures, especially those involving fusions like the lapidus or more extensive proximal osteotomies where more bone healing is required, often necessitate a period of strict non-weight bearing or perhaps heel weight bearing only.
How long is non-weight bearing usually?
This typically ranges from a few weeks up to perhaps 6 to 8 weeks, sometimes longer in complex cases, to allow the bones to heal properly without being disturbed by weight-bearing forces. Using crutches or a knee scooter is usually necessary during this time.
So the specific type of surgery really dictates the initial recovery phase.
Absolutely. It's crucial to understand the expected weight-bearing protocol for the specific procedure you might be having. The time to return to wearing regular shoes, even comfortable ones, or to return to work also varies widely depending on the surgery and the type of work. But a common estimate from the sources might be somewhere in the range of 6 to 12 weeks before getting back into supportive trainers, perhaps longer for more fashionable or restrictive shoes.
And activities, sports.
Return to sports or strenuous activity typically takes longer, often 4 to 6 months, sometimes more, to allow for complete bone healing and soft tissue remodeling. The full healing process, including the resolution of residual swelling, which can linger for quite some time, can continue for up to a full year after surgery.
A whole year for everything to settle.
Up to a year for the final result to be apparent, yes. Postoperative care also involves managing swelling, elevation is key, wound care to prevent infection, and eventually, often physical therapy or specific exercises prescribed by the surgeon to regain range of motion in the toe, rebuild strength in the foot muscles, and restore balance and normal gait pattern.
Anything that can hinder recovery.
It's also critical to highlight, as the sources do, that certain factors can significantly impair bone healing and increase the risk of complications after any foot surgery. Smoking is a major one.
Smoking really affects bone healing.
Dramatically. Nicotine constricts blood vessels, reducing blood flow needed for healing. Most surgeons strongly advise quitting smoking well before and after surgery. Other factors like poorly controlled diabetes or peripheral vascular disease can also increase risks.
So even if the procedure itself is relatively quick in the operating theater, the journey back to full function and comfort takes a real commitment to the recovery process. It's definitely about setting realistic expectations.
Precisely. Understanding the recovery timeline and the requirements, the weight-bearing restrictions, the need for therapy, the time off work or activities is just as important as understanding the surgery itself.
We've covered a tremendous amount of ground today, really getting into the weeds of hallux valgus, from the fundamental mechanics to the nuances of diagnosis and the wide array of surgical solutions. Let's try and boil it down now to the absolute key takeaways you should keep in mind from this deep dive. What are the essentials?
Okay. Based on our comprehensive review of these sources, here are what I see as the essential points to remember.
Go for it.
1. Hallux valgus, or a bunion, is fundamentally a complex, three-dimensional deformity involving the bones and the soft tissues of the first ray. It's not simply a superficial bump growing on the side of your foot.
Okay. Point 2.
2. While aggravating factors like tight, pointy, or high-heeled shoes definitely play a role in causing symptoms and potentially making the deformity progress faster, significant underlying risk factors are rooted in your genetics and your inherited foot structure and mechanics. It's often multifactorial.
Right.
3.
3. Non-surgical treatments, things like wider shoes, padding, orthotics, splints, pain relief, are primarily tools for managing pain and irritation and making shoe wear more comfortable. They do not correct or reverse the underlying bony malalignment. Prioritizing proper, accommodating footwear is probably the most effective non-surgical step you can take.
Got it. 4.
4. Surgery is considered when pain and difficulty with function persist despite adequate non-surgical treatment, significantly impacting quality of life. The goal is to correct the structural deformity to relieve pain and improve function. And importantly, there are numerous surgical procedures, often used in combination, which should be tailored by the surgeon to the specific nature, severity, and location of your individual deformity based on that thorough clinical and radiographic assessment.
Makes sense. And lastly, and 5. Post-surgical recovery is a significant commitment. It requires patience, strict adherence to weight-bearing restrictions, which vary greatly by procedure, managing swelling, and engaging in rehabilitation. Full recovery, back to all activities without restriction, often takes many months, sometimes up to a year.
Excellent summary.
And I would just add one final thought, perhaps.
Huh.
Because the deformity is so variable from person to person, different angles, different degrees of arthritis, different levels of instability, getting that thorough clinical evaluation that includes weight-bearing x-rays and precise measurement of those key angles, maybe even a CT scan in some cases, is absolutely crucial.
Why?
Because understanding the specific characteristics and the root cause of your bunion is the key to guiding the most appropriate management strategy, whether that remains non-surgical or progresses towards a specific type of surgical intervention. It's all about tailoring the treatment to the individual anatomy and problem.
That's an incredibly clear and valuable summary. This has been a truly insightful deep dive into a condition that is so common, but clearly far, far more complex than many of us realize. Thank you so much for expertly guiding us through these detailed sources today.
My pleasure entirely. The material provides a rich understanding of the biomechanics and the evolving management strategies for this condition.
And thank you for joining us on this deep dive. If you found this exploration helpful, please do consider sharing it with others who might benefit, perhaps colleagues or friends dealing with this issue, and leaving us a rating wherever you listen genuinely helps other curious minds find the show. As we wrap up today, consider this provocative thought. Building on the insight that Hallux valgus is a progressive, complex, multiplanar deformity, and that newer surgical techniques are focusing on correcting the underlying 3D mechanics, sometimes even right back at the TMT joint at the base of the metatarsal. Given that the problem often stems from inherited foot structure and mechanics, things like ligamentous laxity or hypermobility, or that metatarsus adductus foot shape, how might interventions focused on addressing these foundational mechanical issues earlier in life? Perhaps through targeted physiotherapy, specific strengthening exercises, sophisticated orthotics designed to control abnormal motion, or even other non-surgical biomechanical correction strategies. How might these play a greater role in the future in preventing or at least significantly slowing the progression of severe bunions, potentially reducing the need for complex bony surgery later on? Something to perhaps ponder as you think about the intricate engineering of your own feet and the future directions of orthopedic care. We'll see you on the next deep dive.